explaining what these necrotizing myopathies are. Some of you may know a lot about them, some of you may know less, but I tend to think of myositis as being multiple different diseases, and polymyositis as probably multiple different diseases. A lot of patients with autoimmune muscle disease have inflammation in their muscle myopathies. The thing that differentiates the necrotizing myopathies is that there's a lot of muscle damage. It's an autoimmune process, but there's no inflammation in the muscle. And you've probably heard a lot about autoantibodies over the past couple days. And the other thing is that about these necrotizing myopathies is there are particular autoantibodies that go along with these diseases, and the different antibodies probably further subdivide the necrotizing myopathies into different diseases. So the two main autoantibodies that we see in patients with necrotizing myopathies are antibodies that recognize SRP, which is the signal recognition particle, so anti-SRP myositis. And the other one is anti-HMG-CoA reductase autoantibodies, so anti-HMGCR. So those are two antibodies that are very specifically associated with the necrotizing myopathies, the autoimmune necrotizing myopathies. And anti-SRP myopathy, unlike some other forms of polymyositis and dermatomyositis, it mostly just affects muscle. Some people have a little skin, a little joint involvement, but nothing. Usually there's not interstitial lung disease or severe arthritis or severe skin disease. It's really predominantly a muscle problem. And it turns out it's actually one of the most severe types of polymyositis that we see. So anti-SRP, many of our patients, if they're not treated really aggressively, will have not a good course. They can, even with high-dose prednisone, they can continue to get worse. So it's among the more severe types of autoimmune muscle disease that we see. Not that everybody who has anti-SRP is severe. There are also examples of patients who respond very well to treatment. And the anti-HMG-CoA reductase patients, those are the patients who have a particular tendency to have their disease triggered by statins. So all of the patients that we've identified as statin-triggered autoimmune muscle disease almost all of them have necrotizing myopathies, and they have these antibodies that recognize HMG-CoA reductase, so we test for those. In terms of treatment, we think that it's really important to recognize not just that you have a necrotizing myopathy, but which form is it? Is it anti-SRP? Because we think those patients respond to a particular set of therapies particularly well. Or is it anti-HMG-CoA reductase? Because we think those patients actually do best with a different course of treatment. So those are kind of the two main branches. You've got all this polymyositis, then you've got the necrotizing, and then the further subdivisions are the SRP and the anti-HMG-CoA reductase. There may be people who are antibody negative or have antibodies we haven't identified. Those are much more confusing for us. We know less about those patients. So that's sort of what I would tell you without my pictures and actual talk, just to sort of get the ball rolling so that everybody kind of has at least heard the words that we're going to talk about. Yeah?
But just so we're all on the same page, is necrotizing myopathy a pathological diagnosis?
That's exactly right. So, necrotizing myopathy. So this is confusing. There are different ways to divide up myositis, and some people like to divide it up based on what the muscle biopsy shows. So Alan Pestrom, for example, who you guys all met today, if you haven't met him before, he is a muscle pathologist, and he wants to divide up the different types of myositis according to what the muscle biopsies look like. And so if there's a necrotizing myopathy, that would be sort of one histological group. Now he thinks that he can subdivide them according to what kind of antibodies they have, but when people say necrotizing myopathy, they pretty much mean what's the histological diagnosis. I tend to think of the muscle diseases by what autoantibody they have. I'm not saying I'm right, there are different ways to do it. So I think of, if you tell me what your antibody is, I feel like I know exactly what disease you have. You tell me you've got Joe1, I know, you're at risk for lung, joint, mechanics, hands, possibly skin, muscle. If you tell me you have SRP, I know it's going to be almost all muscle. I know you're going to respond to different medications in those. But here's the problem. Some, like anti-Jo1 patients, anti-synthetase patients, if you look at their muscle biopsy, it may be necrotizing. So about 50, when we look at all of our dermatomyositis muscle biopsies, for example, 15% of them are necrotizing. Okay, so some people might call those people having necrotizing myopathy. I would say they have dermatomyositis. For me, immune-mediated necrotizing myopathy, even though it has necrotizing in the word, it's really, I'm talking about people with anti-SRP or anti-HMG-CoA reductase autoantibodies for the most part. That's my long-winded explanation. And if it's confusing, if it sounds confusing, it's because we don't all agree on how these things should be divided up. And so there are different ways of doing it, and probably none of them are perfect. But necrotizing refers to what the muscle biopsy looks like.
While we're reading,
Yeah, sure, please just.
I don't know if you can speak to this one
Yeah.
last question. I was just recently at one of the doctors that said that when you are doing studies in regarding unknown identified antibodies.
So, I don't know so the NIH has an undiagnosed disease program, which is different. So there's a program for people who have like whatever disease that nobody's been able to figure out what it is. That's the undiagnosed disease program. I'm not sure if that's what they're talking about. As far as I know, there's no specific protocol set up at the NIH to identify new autoantibodies. At Hop, so I met both at the NIH and at Hopkins, and at Hopkins we are doing that though. So we're if all of the patient sera that we collect at Hopkins, we use all the time to try to identify new autoantigens. So like we identified the anti-HMG-CoA reductase autoantibodies using all the sera from that cohort. So most of the novel autoantibody identification projects are happening, the ones that I'm involved with are happening at Hopkins. Other people, Chet Otis and Steve Greenberg, they all do similar work, but there's less going on at the NIH. Well, it's not necessarily, so if you go to Hopkins, we're going to use your serum to look for novel autoantibodies if you don't, but part of the problem is we can't actually tell you if we find one in there. So like, let's say I found that you have a new autoantibody. Because we're a research lab, we can't use it for clinical purposes. So we tend to collect your blood for our research, but we also take your blood and send it out to the commercial labs so that they can test for these things, so we can then use that information to guide clinical decision making and put in your medical record. And we sometimes cheat, but we'll never put it in writing. Sir.
When I did my myositis panel and came back positive for SRP,
Yeah.
they had a couple like subtypes, there's two different numbers like it. SRP, that's something like 74 or 50 something.
Yes. Yeah. So.
Significance to that.
Yeah. So SRP, the signal recognition particle, is actually 6 different proteins and an RNA molecule that all form like a complex. And you can make autoantibodies against all those different components. So there's a 72 kilodalton and a 54 kilodalton. Kilodalton is a size, how big the protein is. So the 72, the 54, and so on and so forth. And depending on where you send your blood, they do the test differently. So they may or may not report back what exactly your autoantibodies recognize. We're actually doing a study right now. We've got in our cohort about 35 anti-SRP positive patients. And so we're actually looking to see, do people with autoantibodies against the different components, because everybody has different people have different patterns. Do certain patterns correspond to different clinical characteristics. For example, I've got some SRP patients who are doing great, who respond to treatment, and they're just doing great. And I've got other ones that are very severe and very difficult to get under control. And I'm wondering, can I predict who's going to do well and who's going to do poorly based on that? There may be other factors. A lot of the most severely affected patients with SRP in our experience are young African American women. They are very difficult to control. Older Caucasian patients with SRP seem to for some reason do better. Why is that? So we're interested in those kind of questions. Any other questions?
Okay.
Yes.
Okay, so, because the muscles inside, so at some point, will they stop regenerating and we just will kind of lose all kind of, wheelchair bound? I don't know.
So this comes up in SRP, in the necrotizing myopathies a lot, about muscle regeneration. So normally, if you have no muscle disease, there's very little muscle damage and very little muscle regeneration going on. If your muscle is being damaged, you can do well and have good strength if there's a little bit going on, because you're also able to regenerate muscle. And so as long as your muscle regeneration is able to keep up with the muscle destruction, you're going to do okay. In patients where the muscle destruction is outpacing the muscle regeneration, that's when patients tend to get weak. So we treat patients with our prednisone, other immunosuppressive agents, to try to decrease how much damage is going on and try to maximize the regeneration. Now, in some patients with SRP and HMGCR, the necrotizing myopathies in particular, some of the patients we have high CK levels, even though they're really strong. So I've got some patients who feel they have totally normal strength, they look like they have normal strength to me, but their CK is still 10 times normal. So they have their disease is still going, but for some reason they're able to keep up with it by regenerating muscle. And the question for me always is, well, this relates to your question, should I be treating them more aggressively because someday their muscle's going to lose the ability to keep regenerating? Do people always maintain the ability to regenerate the muscle, or is that going to burn out someday if I'm forcing them to regenerate? I don't think any of us know the answer to that. And so, like in a patient who's got normal strength and feels good, and their CK is still 2,000, I don't know whether we should. My whole point of view was we shouldn't be treating those patients any more aggressively than we already are. Because why would I expose you to more risk of side effects from adding an additional medication when you're not going to feel any better for being on it? I'm just sort of treating the number. But interestingly, I had a patient who I told that exact same thing to. She was an anti-SRP patient. She thought she was doing great, but her local doctor wanted to give her add IVIG to her regimen. And I was like, you're totally strong. You feel fine. And I said, is there anything, are you feeling impaired in any way or weak? And she was like, no, I feel fine. But then she went back and her doctor and her decided to do the IVIG. And her CK was like 1,500. They decided to do the IVIG anyway. Her CK normalized out, but more importantly, she could then run. She hadn't been able to run before. And so she was back out to running like 5Ks, 10Ks, things like that, which she had sort of reset what her normal was. So she was telling me that she felt normal and didn't have any limitations. But then when they actually gave her the IVIG, it did actually improve her. She didn't recognize that she could improve more. So, we learn as we go. And that sort of made me think, well, maybe there are people who would benefit from an additional treatment. So I have patients who are like her, who feel really well, who still have the high CK levels, but maybe they have still a lot of fatigue or something, who I've tried to offer them additional treatments. Most don't want to do it. Most of them are like, I feel fine now, why do I want to risk adding another treatment? And I respect that. I don't know for for sure what the right answer is, but I offer patients that more now, based on that one experience I had, where I think I was wrong about trying to, not recommending that she do that medication.
Going back to our request line, if you don't have the anti-SRP, then we're talking about the
HMGCR.
statin or statin.
30% of the patients that in our cohort never had a statin.
And you don't have
And they still have the antibody, and they still have a disease that looks a lot like the people that did have the statin.
Okay, but do those people have anti or not?
So if your SRP,
Anti-SRP.
so say it again. Let's start at the beginning.
Okay, so I don't have
You don't have
I
SRP.
don't have SRP.
There's a necrotizing myopathy, but no SRP,
No SRP.
and you haven't been tested for HMGCR.
I don't know.
Probably not. It's only been around for the commercial
So
test
that
is
you can,
HMGCR. It's only been around for a couple of years.
but that statin, that you're saying 30% of those aren't statin.
30% are not statin.
Okay.
So you can still have, it's a common misconception that you have to have had a statin exposure, have that antibody. Many do, but some do not.
So we're a little confusing.
So it's worth checking for it. And one of the reasons why it's worth checking for is we really think that IVIG works particularly well for that disease.
Yeah.
Yeah.
I mean,
IVIG, we don't think works particularly, there are cases where it does work in anti-SRP patients, but anti-SRP patients tend to do better with rituximab as a medication. Yeah. Sorry, good question.
I have a question.
Yeah.
I had some, I'll call them lumps, but
Calcinosis.
it was,
A lot of times lumps are
but they were biopsied, and I didn't find a nail, but when they biopsied, it was necrotized. That was part of what it was. It wasn't all, there was necrotizing factors inside them.
but it wasn't muscle.
No.
So I'm not sure what that was, but it wasn't
I
this.
didn't know if this said it was histoplasmosis, but they weren't sure if that's really what caused it.
Right.
Because it was throughout my body.
I don't know the answer to that, but what I'm talking about is, so you can have other tissues. Necrosis just means dying. So you can have biopsies of other tissues, like lipome, like fat, or basically anything else that will show necrosis. But the necrotizing and the necrosis we're talking about is, I'm talking about is the muscle that's necrotizing. Yeah.
Yeah, just a couple things. I was talking about that patient you're talking about, right? They kind of actually discovered the ICK when I talked to them.
Yeah.
In retrospect, I wish I would have attacked my question,
Yeah.
because eventually it did kind of get worse. But the other thing, I did have a doctor give me statins, and I have an SRP antibody.
Yeah.
Statins did trigger my CK, and I got a lot more strength.
So that's really interesting. To the best of our knowledge, statins aren't a common trigger of SRP, but I don't know that we've looked at it carefully enough to say that for sure. There are some people, probably 5 to 10% of just the general population, who don't react well to statins. Who get a little bit of muscle damage from it. And in a normal person, they might just bounce back from that pretty quickly. It might just be muscle pain or something like that. But if you're one of those people, and then you also have anti-SRP, it could be that the statin is going to really exacerbate the underlying autoimmune disease. We don't understand that very well. In general, we think it's okay for patients who have various kinds of autoimmune muscle disease to be on statins and try them. But we always recommend, if you're going to start one, to just pay close attention to, is the CK being stable? Are you staying well? And sometimes we do have to take patients off if they have a reaction, but it's relatively rare, except in the HMGCR positive patients. Many of them cannot tolerate going back on the statin.
Can I ask her about when I first got diagnosed with full steroids and Imuran? The Imuran worked for a year, failed,
Yeah.
started falling all over the place.
Yeah.
They sent me down to, I saw Dr. Louie.
Yes.
And
CellCept.
CellCept.
Awesome.
So,
Yeah.
but I'm at maximum dose.
Yeah.
So my rheumatologist said, if we fail that, then I will come back to you guys. Or, so you're suggesting now at that point that the Rituxan would still be an option if the CellCept stops working?
Yeah, so it's true that most of our data of people doing really well with Rituxan is African American.
That's what Dr. Louis thought.
That's true. So I think that, have you ever done IVIG?
I have not.
Yeah.
We haven't really felt the need.
Yeah.
I discussed it with my rheumatologist.
Yeah.
I'm a nurse, I'm med
Yeah.
surg, I still work full-time.
Yeah,
I can still drive.
yeah.
So at this point, we kind of thought, let's just sit. But if I get a decline in function,
Yeah.
I'm absolutely willing to try it.
Yeah, I don't think any of us can tell you what the right answer is.
Sure.
But I think either IVIG or Rituxan would be reasonable if CellCept is no longer doing the job. One thing I would say is, when SRP gets out of control, it can be really hard to get it back under control. I think I'm not the only one who's seen this, where I had a patient who I had really under good control. I lost track of her a little bit. She needed some surgery, and the doctors took her off all our medications like a month before the surgery, and she was fine for like a couple months. But then I saw her, and she was terrible, and I've never been able to get her back to where she was. Even now I've stabilized things out, but she lost a lot from that. That's the other thing about these, both the SRP and the HMGCR, is if they are allowed to sort of rage on, unchecked or suboptimally controlled, you can get permanent muscle damage from that, faster than probably other forms of muscle disease, because the muscle tissue can convert to fat, and you can't convert the fat back to muscle. So that's the other thing. You know, sometimes there's a question about, boy, I'm still weak. You know, so the question is that because you're being not treated aggressively enough, or is that because you have permanent muscle damage? In most of the patients with SRP and HMGCR, the necrotizing myopathies, if your CK is not elevated, you probably don't have active disease. So if your CK is not elevated and you still have weakness, it could be that there's permanent muscle damage. And the way to find out is to do an MRI of the muscle. Because then you can see whether it's fat or whether it's edema from inflammation.
The MRI indicated a lot of edema when I was there a year and a half ago.
So that would be an indication to be more aggressive.
And my CK runs about 200 on the CellCept.
200 is pretty darn
It
good.
is.
Most people
It
take
is.
that.
Yeah, yeah.
Yeah. And CK in most diseases, not most, in dermatomyositis and stuff, I don't follow, I mean, I follow the CK, but it's not like such a big deal. In the necrotizing myopathies, the CK is a pretty good indicator of disease activity. Because the reason you get an elevated, CK lives in your muscle cells. And normally very little leaks out, you don't detect much in your blood. Only when the cells are breaking open does the CK level go up. And that's what's happening in necrotizing myopathies, is the cells are dying and breaking open. So the CK tends to be a very good indicator, we think, of disease activity.
So if it continues to remain at that level, the CellCept is doing its thing. If it starts to go up at all, then I should.
I mean, I don't know you super well. As a general rule, I would say with people who have SRP, have necrotizing SRP, and their CK is normal or close to normal, I don't think that they usually need more aggressive immunosuppressive therapy. There may be some other factors in there, but that'd be as a general rule. Yeah.
So I'm trying to learn about the new normal because for 15 years I just had myositis.
Yeah.
And, you know, occasionally it flared and we'd up with prednisone and,
Yeah.
you know, on I went. And then 2 years ago I went to Hopkins for the first time and as a result found out that I'm anti-SRP
Yeah.
and necrotizing myopathy. So we fooled around with some of the meds that I was on, but the bottom line was I'm off of everything now except a little bit of prednisone, and I did my first Rituxan a year ago.
Yeah.
And so my local rheumatologist said, okay, Rituxan every 6 months, that's the way I do it. And I said, okay, so I went back to Lisa and said, do we do it every 6 months?
Yeah.
And she said, no, let's wait and see what happens with it.
Yeah.
So what I'm seeing is my CK is beginning to climb, and it's now at like 650.
Yeah.
It was down around 250 when
Yeah.
we did the Rituxan, so.
I mean, after the Rituxan?
Right at about the time we did it.
Yeah.
But I was getting very weak.
Yeah.
My CK was relatively normal for me,
Yeah.
which is the 250 to 350 range. And so, you know, I was perfectly happy with my IVIG, methotrexate, and prednisone. But once we discovered that I didn't have polymyositis, or at least I got poly plus. So what I'm trying to get my head around is, you said something a couple minutes ago about if SRP gets away from you,
Yeah.
you know, it's harder to bring back.
Yeah.
And I'm thinking, oh my goodness, what could make it get away from me? And then you said, when the CK begins to decline, this could be an indicator.
Yeah.
And I can't tell you that I'm weaker, I
Yeah.
mean, if we had a good objective test. But it sounds to me like I need to go back for another retux.
If you have SRP and your CK starting to rise, it's definitely time to revisit whether there's something to do or not. No, in the past, I would wait until I saw people get weak. But I'm starting to, in some patients, the CK is a pretty good indicator that if they're not weak yet, they're going to get weak. But where that is different for different people. So I have some, HMGCR positive patients who live at 2,000 or 3,000 and they just seem to be fine. I mean, on treatment. And they might go as high as 4,000 or 5,000 before they start to get weak. Other patients start to get weak at 1,000. I don't know why that is. So everybody's different. But I would say if there's a trend that things are moving in the wrong direction, especially if what you're thinking about adding is Rituxan, you want to think about doing it before things get a lot worse, because Rituxan takes a while to work.
Well, I had it 1 year ago.
Yeah.
My first 2 doses
Yeah.
were just over a year ago.
So we often give it every 6 months, like your local doctor does, but it sort of depends on the circumstances. You know.
Time to ask the questions.
I think it's time to bring it. Like I would go see Lisa and say, look, my CK is starting to go up. It was 200, now it's 650. Should we consider doing something? I'm not saying the answer is yes or no, but it is time to address it.
You said that you could tell about the muscle if they do an MRI.
Yep.
What if you can't do an MRI because you have a pacemaker?
So it's not always necessary to do an MRI. It depends on the situation. If we desperately feel like we need to get an MRI on somebody, often we can get it done even if a patient has a pacemaker. At least at Hopkins, there's one MRI machine that's set up specifically for patients who have pacemakers. It depends what kind of pacemaker you have, but often what they can do is tailor the study, and then at the end they have to reset your pacemaker. And so cardiologist has to be there during the MRI. So it's kind of a big deal to set up. We only do it in situations where we really need that information to make a decision.
I read some literature that as the disease progresses, sometimes the CK doesn't really even really correlate that well on how you're doing this function. And like when I was diagnosed with CK was 21,000, I was walking going to work, and
It's amazing, isn't it?
It was.
Yeah.
And so, they treated me and everything, and now I'm resistant to treatment. I am, weaning myself off the prednisone. And to me, I can't correlate and say, when my CK is higher, I feel worse, I feel better. So that's why I'm like, when they tell me you need this treatment, I'm kind of hard-headed because I'm like, I feel fine.
So, I totally hear what you're saying. So I'm
Patient, I've numbered it.
I think that, so I tend to treat the weakness and not the number as a general rule. But some of the, we might be different, but some SRP and HMGCR populations, the CK does really serve as an indicator for where things are headed. And especially if I've known a patient for a while, and I've seen that, boy, every time your CK starts going up, that means in a couple months you're going to start to get weak. Then I will act on that CK number. But as a general rule, I agree with you that I wouldn't want to take a medication that's not going to make me feel any better. Unless there's some really darn good reason to do it. And so you may be different. The other thing about CK is, and SRP and HMGCR, is if you've had the disease for a long time and it's gone unchecked and you've had a lot of fatty replacement of your muscle, then your net CK is never going to be high as it was, right? Because if you're super muscular and you start having muscle damage, you're going to release tons of CK into your bloodstream. But if you've had the disease for a long time and your muscle bulk is lower and some of it's replaced by fat, even if you're really sick, your CK may not go up all that much. That's like our IBM patients, our sort of late stage IBM patients, even though they may have a normal CK, because they don't have enough muscle left to have a high CK. So there are all these little things that you have to individualize for each person. That's why it's so hard to make general. That's why we come up and we try to make general statements, but there's always the exception, and they don't apply to everybody. Or we make people come to see us in clinic instead of just having like a website.
I did have MRI, fat tissue.
Yeah.
But my CK does go up, it goes up to like 6,700.
Yeah, sure.
So, is that a contradiction?
No, it just means that it's not everybody. What it means is you have enough muscle. You have enough muscle so that you, when your disease is active, that you still mount a pretty darn high CK level. So I wouldn't. That just is what it is. It's good, I guess. You don't want to have high CK, but it is telling you that there's enough muscle left that when it starts being damaged, you get a super high CK level. Hardly anyone can sustain a CK of like 6,000 or 7,000 without getting weak.
Yes.
I see it at a few thousand. Early on, I used to sort of watch and wait for people to get weak. Now I know, but I do know. No, when their CK started going up, if they were fine, like you were saying, I'd see people whose CK was 2,000 and 2,500 and 3,000 and 4,000. Some of them would be fine up to that point. I'm like, whoa. I don't want to start treatment on those patients. But what I learned is, if that's what's happening, they are going to get weak. So now I will encourage them to pull the trigger on starting the treatment before the weakness hits. Because you don't want, because then it takes a while to turn the big ship around and start getting stronger.
Could you get any data on how stress may affect the CK?
So that's a great question. There's no good data on it, but I'm pretty well convinced that stress affects autoimmune disease in general. Certainly myositis patients talk about it all the time. But we don't know we're not good at measuring it, right? Scientists are good at things that we can measure. And it's like, how do I measure how stressed you are? It's hard. It's a good question. So a lot of people feel like their disease flares under stressful conditions, and I bet that it does. Yeah.
I think I'm in that category, or possibly, this is polymyositis and anti-SRP necrotizing.
Yeah.
I've been on high doses of prednisone that cleaned over the year and doing well at being around that 50 milligrams daily now. They're not pieces on remission.
Yeah.
If I were to go backwards and think about it, as the doctors asked me, I think prednisone did really well. I think it was the inulin. So do you agree? If I went to relapse also, I want at least I can quote you that the best natural thing to go to would be to be detoxing?
Well, one thing, you're on a super low dose of azathioprine. So my first thing would be to increase your dose of azathioprine. Again, this is like, I don't know what your white count looks like and all that. But in general, that's such my strategy with the different medications is to max out a medication before deciding that it's not working and needing to add or switch to something else. So 50 milligrams of azathioprine, I'd frankly be surprised if 50 milligrams of azathioprine is enough. But it might be for you. Everybody's different. People metabolize it differently. But my thought would be, since you know azathioprine worked, to increase the dose of that. But if that failed for SRP, I would probably, race things being aside. I tend to go to Rituxan or IVIG. The thing about IVIG is it tends to work faster. So in reality, if I have an SRP patient that is tanking, I usually do IVIG and Rituxan. Like if somebody's really going downhill, because I'm thinking, well, the Rituxan is the long-term thing, but I need something now. And so if they're already on prednisone or prednisone's failed or whatever, I will often do like 2 or 3 months of IVIG and giving Rituxan, starting the Rituxan at the same time. That's in the severe, that's like patients who are not walking and, you know, where things are just really not looking good.
Next question. Is it possible IBM patient can be diagnosed with necrotizing myopathy?
So there are some IBM patients who have necrotizing myopathy, have necrotizing muscle biopsies with very little inflammation and maybe no red backfills. I've seen it a couple of times. So I think the answer is yes. I always wonder whether they don't have something different.
But should be also inside the pathology report, right? If it's
Yeah. So it gets back to this question. Like, so I think of, I feel like I only understand what's going on when I know what the antibody is, to be honest with you. If I don't know what antibody you have, except for IBM, with autoimmune muscle disease, if I don't know what autoantibody you have, I kind of feel like I'm in the dark. Unless you have, well, there's some dermatomyositis patients where they clearly have the rash, and I know you have dermatomyositis, but there are other things I don't know about you. For polymyositis, man, I really feel like I need to know the antibody, or I just don't really fully understand what you have and what you're going to be doing. So I like knowing the antibodies. Yeah.
Right, but if we have an unknown antibody,
Yeah.
we don't know what the symptoms are. You mean? I don't know what's coming down the line. Right?
So you don't have SRP?
SRP.
Yeah.
Unknown.
Oh, I'm not worried about the other one.
So how
A lot of people have these unknown things. So it's not, I don't know whether it's important or not, but if you take a bunch of patients who have SRP and they all have SRP, a lot of them are going to have other autoantibodies in there. But for the most part, they're against things that aren't shared between patients. So we don't really know what those other things mean, to be honest with you. The SRP tells us a lot. Those other things may matter, but we don't understand if or how they matter. Because again, SRP is really rare. I mean, this is like the biggest collection of SRP patients you're ever going to see, all in one place, unless you come to the clinic, someday at Hopkins. But it's a rare disease. Myositis is rare, and then only 1 out of 20 myositis patients probably has anti-SRP. And then among those, there are lots of different of these other autoantibodies. It's awfully hard to find another person who has that same pattern that you have to try and figure out what it means.
And you have to have a big enough body of enough study.
That's right. That's right.
Not profitable.
So that's why, like, we're 7 or 8 years into seeing SRP patients at the Myositis Center, and we only now have enough longitudinal data where we follow patients for enough years, where we figure where we now feel like we can go and analyze it and try to figure out what's going on with different subgroups.
Do you share that data with others?
We publish it. We tend to publish it. Yeah. So we had a symposium here, a scientific symposium developed medical advisory board yesterday. What I was presenting was our longitudinal data from 110 anti-HMGCR patients. So we've seen 110 at our Myositis Center with the necrotizing myopathies with anti-HMGCR. We have almost 400 individual clinic visits. And for each visit, we have their CK, their strength, their antibody levels, what medications they were on, what race, what age, all this stuff. And we can apply complex biostatistics to help us figure out what's going on. So this is unpublished, but one of the things we learned in just the past few weeks is that with the necrotizing myopathy patients with HMGCR, older patients do much better. So older patients respond much better to treatment than younger patients. So if you're 30 with HMGCR, with what the medications we're currently using and everything, you're not going to do as well as somebody who's 70. Somebody who's 70 would actually do better. It's one of those rare things where the older you are, they actually do better, the prognosis is. And that's the kind of thing we were trying to understand about SRP. I think it's going to turn out to be the same with SRP. that the younger patients don't do as well. Because I have the young, super young SRP patients, especially teenagers and stuff, when they get it, it's very rough. Whereas our older patients, and that used to be mostly what I'd seen. I was like, oh, SRP is terrible. Everyone's just doing terrible. Then I started seeing some older patients who actually are doing pretty darn well. So I think it might be the same with SRP, but that's one of the things we're looking into in the next few months. But we'll publish that. And then we also have information about treatments. So it's pretty darn clear from our experience that IVIG is what works for those patients. And I think somebody mentioned not doing well on steroids. For HMGCR, steroids didn't seem to help that much at all. In fact, they almost seem to make people look worse. And there are some SRP patients that we talk to who are strongly feel when they got put on high-dose steroids, they got worse. And they got better when they got taken off high-dose steroids. And so, again, there are other people who do well on high-dose steroids, but it's complicated.
The IVIG for SRP or for the?
HMGCR. For SRP,
You said it was.
we're studying Rituxan too for both SRP and the HMGCR to see whether they seem to work. I don't think we have the data yet. I think all of us are pretty convinced that young African American women under 40 who have SRP, Rituxan is hands down going to be our first choice. When either other age groups or races, we have less information.
How about Asian women?
So
Do you have Asian?
we don't have a lot of Asian patients. It's interesting. So for the dermatomyositis studies that we do, we collaborate with Dave Fiorentino, who's out at Stanford. He has tons of Asian patients, and his cohort. He sees mostly dermatomyositis though.
That's dermatomyositis.
Yeah. So for this, one thing, there's a couple things. The cancer screening for Asian patients is different because Asian patients are prone to getting nasopharyngeal carcinoma. So whereas Caucasian patients don't get that. So we always send Asian patients who are screening for cancer for an ENT evaluation because you actually have to go and look for it. So that's the one thing that comes to mind as being different. And also, like in dermatomyositis, the Asian cohorts, like there are people studying myositis in Japan, the disease is very different. Like people have an antibody and the disease can be very different in the Asian cohort compared to our Caucasian cohort. So there's an antibody called MDA5. Dermatomyositis patients with MDA5 who are Asian tend to have severe lung and heart involvement. And it's it's a much worse prognosis in the Asian population. Our Caucasian patients actually do pretty well. Yeah.
That's interesting because my brother was 39 and he had the MDA5 of dermatomyositis, and that's exactly, unfortunately, it took his life. But the interstitial lung disease and his heart was just going out of control.
Sorry to hear that.
But it was interesting because I haven't heard a lot spoken about the MDA5. In another session they mentioned it, but it seemed like the percentage of people that have dermatomyositis with MDA5 was much lower statistically than the anti-Jo. Is that
Patients
correct?
that have what, sorry?
Dermatomyositis with the antibody MDA5 seems statistically lower than people who have dermatomyositis with the anti-Jo antibody, correct?
You mean the percentage of people with MDA5?
Yes.
Yeah, Jo is much more common than MDA5.
Right.
And MDA5 is a newly described one. Jo's been around for a long time.
Gotcha.
But we're starting to understand more and more about MDA5. We recognize MDA5 patients now when they walk in the clinic. We hardly even need to do the test.
Really?
They get these very characteristic lesions on the palms of their hands. I don't know whether your brother had that. Ulcers elsewhere that our other myositis patients don't get. Often we can find them. We've actually had, I'm sorry to hear about your brother, but we've actually had more success treating most of those patients than the Japanese.
Oh,
The Japanese are good doctors. I think it's just that they tend to be more severely affected with heart and lung.
Right. Gotcha.
And when you get that, it's not good.
Right.
Yeah.
So you just triggered a really interesting thought in me. When I had my Rituxan treatment. It was treated by a local cancer center. They were the only ones that can
Use
use
the
it.
Rituxan?
And the Rituxan, yes. And they said, we are treating your polymyositis. And it came back on now Medicare, and Medicare said we refuse to pay. So it just hit me. Polymyositis may not be approved for a Rituxan treatment, but, and you may not know the billing issues because I know that's a pain in the big butt, but necrotizing myopathy is a whole different animal, and is it more likely to get approved? If we had changed the wording.
Right.
So we fight this all the time. So I have like a little packet that I have sort of like a packet that I send to insurance companies who deny Rituxan for patients with SRT and other necrotizing myopathies because we have a lot of experience with it. We've published a paper showing that it works. So it's not like FDA approved for that, but we can sometimes battle them down into doing it. And the other thing is Genentech has a program where they will sometimes pay for the drug.
Would Lisa have access to that pamphlet?
The pamphlet.
Well,
the
I'm saying
Genentech.
you have something you send to insurance companies.
Oh, I have it. I don't know what she does. We probably have a very similar thing. I sent her paper. It's her paper that I sent. So yeah, so she has her paper. I'm on the paper too. She did most of the work for that paper. And that's what we use.
Because I've been just dreading, if I need it again, which I am feeling I probably do, going through, they're not going to pay for it, and I'm going to have to pay for it myself.
We don't always win, but we often win. And sometimes, and insurance companies are very funny. I one time had a person where they desperately needed to get CellCept for a variety of reasons. And the insurance company, I took it to like the highest level. It was actually like lawyers from them. It was like a phone call with the judge and everything. And the judge decided against us. He said, you know, they based on this and that, whatever, that insurance company is not obligated to pay for the CellCept. And then the next day they approved it. They wanted to make it very clear that they didn't have to do this. But in their interactions with me, their humane side took over. Like I was dealing with actual people who were hearing about this guy and they wanted to give it to him. So sometimes, because they want to protect their butts, they want to make it very clear they don't have to do this. But then at the end, they sometimes do.
I'm going to change the wording.
Yeah, and Genentech, if all else fails, Genentech can sometimes, is sometimes willing to provide the drug for free.
And they're the ones who make
They make Rituxan.
Okay.
Rituxan.
Thank you.
Yeah. I have to go. I apologize, but my bride is taking me to the airport.